Well, thank you very much, John. Ladies and gentlemen, good afternoon. It's a great pleasure for me for the third consecutive year to be able to introduce and indeed to chair what was created from the Association's lecture for this college into the Sir Robert Shields lecture. And it's also a great pleasure for me to introduce Bob Steele. Professor Bob Steele is, of course, Professor of Surgery in Dundee. He's perhaps better known nationally for his work on cancer screening. He's a member of the Council of the Royal College of Surgeons of Edinburgh and also editor of The Surgeon, formerly known as the Journal of the Royal College of Surgeons of Edinburgh, now a joint publication between the Irish and the Edinburgh College, and has been largely responsible for raising the impact factor up to respectable levels. Now, he's going to talk to us today about surgical outcomes in colorectal cancer. And he's particularly interested, he tells me, in how patients, the disease, as well as the surgical team can influence outcomes. I think this is a very timely topic as the discussion around the variability in surgical outcomes, particularly in colorectal cancer, increases. Because I think the spotlight will inevitably center more and more on the variation in surgical outcomes in the next year or two. So I'm delighted to introduce him to speak to this joint venture, this lecture, the Sir Robert Shields lecture. But many of you should know Sir Robert Shields was a former president of the Royal College of Surgeons of Edinburgh and of the Association of Surgeons of Great Britain and Ireland. He was also one of the foremost academic surgeons of the modern era. He was Professor of Surgery here in Liverpool. And he'll be long remembered for his achievements as a clinical scientist, as a surgical educator, and a huge medical statesman. And it now gives me great pleasure indeed to invite Bob Steele to talk to you about surgical outcomes in colorectal cancer. Bob.
Thanks very much, David. I got to know Bobby Shields quite well on several examining trips with the college, and I can tell you it was like going on a school trip with the headmaster. And he was very, I suppose he had the utmost integrity, and to him, everything that he did had to be excellent. So when I was asked to give this lecture, I thought it would be good to focus on how we strive for excellence in colorectal cancer surgery. And as colorectal cancer surgeons, the outcomes that we are constantly trying to improve are shown here. And I'll try to touch on all of these as we go through this lecture. But of course, achieving good outcomes is not just about expertise and excellence in surgery. It's the result of a really complex interaction between the patient, the disease itself, and the surgical team. And I want to take each of these three factors in turn. Firstly, the patient. So for quite a number of years now, we have been exercised by this observation that our cancer outcomes, and particularly our colorectal cancer outcomes in the United Kingdom, are inferior to those in our Scandinavian neighbours, or some of our Scandinavian neighbours, who have comparable data quality. And you can see here that the 5-year relative survival in Denmark, England and Scotland is worse than in Finland, Norway and in Sweden. But if you look at conditional survival, in other words, survival conditional on the patient surviving 1 year, this seems to disappear. So whatever the difference is, whatever is causing this difference between the UK and Scandinavian countries appears to occur in the first year. And it's been suggested that this is related to disease stage at presentation and quality of treatment. But if we look at this in a little bit more detail, so this is absolute excess death rates from colorectal cancer in the first month after diagnosis. And here you can see England, the black line here, and here you have Norway and Sweden. After about the age of 60, there's a sharp separation. But if we now look at these same data for the interval of 1 month to 1 year after diagnosis, 1 year to 2 years, and 2 years to 5 years, this separation between England and the Scandinavian countries disappears. So it appears whatever is going on is happening, in fact, in the first month. So that makes it unlikely that it's related to disease stage, but perhaps it's related to inferior treatment. Now, if we look at this in even more detail and now look at colorectal cancer survival against average national life expectancy in several countries, you can see that there's a striking correlation between 5-year survival for colorectal cancer and the average national life expectancy at age 65. So what this is telling us is that colorectal cancer survival is closely related to the general health of a nation. And if we now turn to the issue of deprivation, we know that deprivation is associated with decreased colorectal cancer survival. We know that this is again limited to the first month after diagnosis. We know that deprivation is also associated with increased operative mortality and with poor cardiovascular fitness. And we've already heard in this conference how poor vascular fitness can be associated with poor short-term outcomes. So probably what is happening is that the patients that we are treating for colorectal cancer are a bit more deprived and a bit less physically fit than the patients that they see in some of the Scandinavian countries. And this really needs to focus our attention on pre-operative optimization of patients. This has almost been completely ignored until fairly recently, and it's still generally completely ignored. None of us, I'm sure, would try to run a marathon without training for it, but we expect our patients to go through major traumatic surgery without any proper pre-operative preparation. I think it's something we need to focus on in the future. And I want to turn to the disease. Now, we're all very well aware that outcomes, the most important factor in good outcomes, is stage at diagnosis. So if we want to improve surgical outcomes, the most important thing we can do is to detect the disease at an early stage. And the question is, do we do this by looking or persuading people to come forward with symptoms, prompt investigation of symptoms, or do we focus on screening? Probably a bit of both. But we have to say, and this is a recent systematic review published in the British Medical Journal, is that symptom complexes have poor sensitivity for colorectal cancer. The types of symptoms that are caused by colorectal cancer are the types of symptoms that all of us in this room get on a regular basis, virtually. However, or rather in addition, we have found that symptoms in a fecal occult blood test screen positive population who are undergoing colonoscopy, and about 50% of these people have symptoms, do not in any way predict the presence of neoplastic disease. So in my mind, I suppose I would say this, but in my mind, the only reliable way of detecting cancer early is by screening, at least colorectal cancer. And here we have the Hemocult-2 guaiac fecal occult blood test, and this is Jack Hardcastle's hand. And Jack Hardcastle, of course, was one of the great pioneers of colorectal cancer screening, running the Nottingham trial using the Hemocult-2 guaiac test. And I was his senior lecturer and reader from 1990 to 1996, where I developed my interest in screening. And we now have the results of 4 population-based randomized controlled trials which consistently show significant reductions in colorectal cancer mortality. And as a result of these trials, a pilot was carried out in Scotland and England to demonstrate that this was feasible within the NHS. And after the successful completion of the pilot, programs have been rolled out based on the guaiac fecal blood test across the United Kingdom. They're all slightly different in the 4 constituent countries, but the whole country is now covered by fecal occult blood test screening. Not sure if Ireland is completed yet, or Northern Ireland is completed yet. And in fact, the Republic of Ireland is just about to start screening as well, although using a different approach. Now, these are the first mortality data that we've managed to derive from the UK programme. And for 6 years, for the first 6 years, only about a quarter of the Scottish population was invited for screening. And the red line here shows the cumulative colorectal cancer mortality in the population that was invited for screening. And the black line shows the mortality in a population taken from Scotland that was not offered a screening, but individually matched for age, gender, and deprivation. And overall, we find that using this approach, we found a relative reduction in colorectal cancer mortality of 10%, and when adjusted for participation, in other words, just looking at those who participated, this reduction was a quite impressive 27%. And this is almost exactly what was predicted by the randomized controlled trials. So I think we can confidently say that colorectal cancer screening does what it says on the tin, but we have really significant problems still to overcome. So the overall uptake of fecal occult blood test screening in the United Kingdom hovers around 50%. And you can see that it decreases with increasing deprivation, and you can see that it's less in men than in women. We also have a problem with interval cancers. And interval cancer is a cancer that arises after a negative screening test. In other words, it's a cancer that's probably been missed by the screening test. And we found that after round 1, this was 31%, went up to 47% after round 2, and it almost reached 60% after round 3. So overall, in the first 6 years, about 50% of the cancers arising in the population that were actually screened were not detected by screening, in other words, interval cancers. Now, we shouldn't be too surprised at this, as this is exactly, again, what was predicted by the randomized trials, but it is a problem, and I don't believe it's sustainable to continue with a screening program without trying to improve the interval cancer rate. And if we look at... it's not moving. Yeah, thank you. If we look at this interval cancer rate in a little bit more detail, you can see in the screen-detected group there are more men than in women, whereas in the interval cancer group there are more women than men, which indicates that this screening test tends to preferentially miss cancers in women, which is quite a serious problem. And if we look also at the site distribution, so yellow is right-sided cancer, green is left-sided cancer, red is rectal cancer, the proportion of left-sided cancers is higher in the screen-detected group than in the interval group, but the proportion of both right-sided and rectal cancers is higher in the interval group than in the screen-detected group. Again, showing that we tend to underdiagnose both right-sided and, surprisingly, rectal cancers by this screening process. So these are the issues I believe we need to address with screening. The uptake, the interval cancers, this gender inequality, and the issue of rectal and right-sided cancers. And perhaps the most obvious way to address these issues is to look at a different screening test. And of course we have a different screening test. We have once-only flexible sigmoidoscopy delivered at around about the age of 60. And you can see here significant reduction in mortality from this very well-conducted randomized trial headed up by Wendy Atkin. And even more excitingly, the flexible sigmoidoscopy appears to reduce the incidence of colorectal cancer. And if we look only at left-sided cancers, and if you look at this orange line, which are the individuals who actually underwent the flexible sigmoidoscopy, you will see that after the initial diagnosis of the cancers that are prevalent at the time of the screen, a single flexible sigmoidoscopy almost protects you completely against developing left-sided colorectal cancer for about 12 years. This is a truly remarkable effect. However, unfortunately, and perhaps unsurprisingly, it has no effect on the incidence of right-sided cancer. So the potential advantages of flexible sigmoidoscopy are that it prevents disease, presumably because of enhanced detection of left-sided adenomas. It's obviously very good at detecting rectal cancer, and there's unlikely to be a gender difference. The disadvantages, or the potential problems, is that all the evidence that we have to date suggests that the uptake is unlikely to be more than 30% in the general population in Britain, although this will vary from one geographical area to another. And there is a possibility that it will actually increase health inequalities rather than decrease them. And there doesn't seem to be an effect on right-sided cancers. So is there an alternative? Well, there is. And that, of course, is to increase the sensitivity of the fecal occult blood test. And this is now easy to do. Here's the guaiac test that we're currently using based on the guaiac reaction, and it's not specific for hemoglobin, and it's messy, unpleasant to do. Whereas fecal immunochemical testing, because it's immunological, it is specific for human hemoglobin, it's easy to do, we know it's associated with better uptake, but above all, it is quantitative. You can actually get a readout of the amount of hemoglobin in the feces. And these are some results from a pilot or an evaluation that we carried out in Scotland using quantitative fecal immunochemical testing as a first-line test. And here you can see the cutoff that we used, and we used this cutoff of 400 nanograms per mil because it was similar to the sensitivity, or the analytical sensitivity of the guaiac test. And this produced a 2% positivity, and we estimate on the basis of our previous data to have picked up about 50% of the cancers. However, if we were to drop the cutoff rate that triggered a colonoscopy to 50 nanograms per mil of buffer, which of course is very easy to do because you just set the computer at a different level, then we would get 10% positivity, but we would probably almost certainly pick up 95% of the cancers. So the question is, do we attempt to colonoscope 10% of the population, or do we attempt to do flexible sigmoidoscopy on 100% of the population? And the answer to that, of course, is not yet clear. So, in my view, the future of screening is to move rapidly to using quantitative FIT so that we have the opportunity to increase the sensitivity. We need to find out where endoscopic screening actually fits in, and you will know that in England, the pilots of flexible sigmoidoscopy have already started. And of course, we need to keep our eye on novel disease markers as they emerge, because we may find something that's much more sensitive and specific in the future, although there's nothing immediately obvious. Now I want to focus on the surgical team. Now this is the surgical team. It's not a multidisciplinary team because I'm not going to attempt to address imaging or adjuvant therapy, which of course are very important in the global outcomes. But I want to focus very much on surgical outcomes. And I don't apologize for putting the surgeon at the top, because if he or she doesn't get it right first time round, then the efforts of the rest of the team can be largely wasted. And the aims of surgical treatment, very simple. We're all very familiar with this. We want to achieve low morbidity and mortality, rapid recovery to good quality of life, and of course, cancer control. So if we think about morbidity first of all. Now, in this era of laparoscopic surgery, which relies very heavily, of course, on stapling, it's become rather unfashionable to talk about anastomotic technique. But I'm going to anyway, because it does have such a profound influence on the patient if an anastomotic leak takes place. Now, this is a very rare photograph. He wasn't very keen on having his photograph taken. Very rare photograph of Norman Matheson. Now, I'm sure that everybody over the age of 50 in this room is very familiar with Norman and his work. But I suspect that younger colleagues may actually never have heard of him. But his work influenced several generations of surgeons. And really, to summarize it, was that he developed this technique of single-layer appositional interrupted serous submucosal suturing, and his initial series here of 200 patients demonstrated an anastomotic leak rate of 1.5% and after anterior resection of 2%. Now, for a while, there was great interest in comparing stapling and suturing. And here is the suturing technique with a careful positioning of the sutures in the serum submucosal plane to achieve apposition and a tension-free anastomosis. But the problem with comparing stapling and suturing was that the trials really were not of sufficiently high quality. And this meta-analysis and systematic review published in DCR in 1998 concluded that there really was insufficient evidence to compare suturing and stapling, although it was possible that stricturing may be commoner after stapling. However, if we look at what we accept as standards for anastomotic leakage, and these are Scottish standards which are still current, we accept a 5% colonic leak rate, a 10% rectal leak rate, a 20% leak rate with a total mesorectal excision. And yet, if you look at the published series of experts or enthusiasts, or whatever you want to call them, using the serosubmucosal technique, you see anastomotic leak rates of 1%, 2%, even less than 1%. So it is very clear that excellence and expertise in anastomosis pays dividends. And whenever we look at anastomotic leak rates in any series, we need to bear this in mind. And there has also been debate about whether we should be defunctioning after low anterior resection. But there are now 3 meta-analyses and 1 systematic review which show that a defunctioning stoma after a low anterior resection reduces leak rates and return to theatre. And this leads on to the bowel preparation story. We've already heard in this conference that there's a Cochrane review that shows from randomized trials that bowel preparation has no benefit and may indeed be harmful. But how does that work? If you have done a low anterior resection and you defunction it to protect it, and the colon is full of feces, is that really going to work? And indeed, there is now one randomized controlled trial from France, which is restricted to anterior resection, unlike these other trials. And indeed, this trial shows that preoperative bowel preparation reduced septic complications. And here we have the result of a patient with low anterior resection, coloanal anastomosis, defunctioned, small leak, but not sufficient bowel preparation to prevent him requiring a reoperation. So everybody gets complications, everybody gets anastomotic leaks, but do some surgeons get more than others? And of course, we know that this is the case, but it's only recently that the data have emerged to demonstrate this very clearly. And this is an analysis of HES data and reoperations in colorectal surgery. And when adjusted for variables, it shows that there are a number of outliers. Now, we can argue about the validity of this particular paper, but there is no doubt that there is variation in outcomes in terms of operative morbidity across the country. And I believe that as a community of surgeons, this is something we have to grapple with, just as our cardiac colleagues have done after Bristol. Recovery, very briefly on recovery. So we're now very familiar with the early recovery after surgery programs, and there's no doubt from many studies that this does enhance recovery. We also know from randomized controlled trials that laparoscopic surgery produces more rapid recovery, less postoperative pain, lower complication rates, albeit at the expense of longer operating times. There's some debate about whether cancer outcomes might be better with laparoscopic surgery, but the overwhelming evidence appears to show that they are equivalent. So the question is how do the ERAS programs and laparoscopy fit together? And back in 2002, Kellett and Wilmore found that an early recovery program with open surgery actually produced a shorter hospital stay than laparoscopic surgery without an early recovery program. So, of course, now the big question is what does laparoscopic surgery add to early recovery programs? And there is at least one randomized control now published, I believe, in fact, there are 2, but there is at least one from Sweden, very recently published in the World Journal of Surgery, which demonstrated that the addition of laparoscopic surgery to an ERAS program brought about a median reduction in stay of 2 days. And of course, we are now all very eagerly awaiting the results of the UK Enroll trial. And I just heard from Robin Kennedy yesterday that the target recruitment has been reached. So we will have some very high quality data on the addition of laparoscopic surgery to ERAS in the very near future. But just a brief word of caution. So this is a multiple regression analysis for reoperation taken from that same paper on variability. And what it shows is that laparoscopy is a significant risk factor for return to theatre after surgery. So what's happening here? There's something going on. So our trialists are finding that there are lower complication rates with laparoscopic surgery, and yet out in what you might call the real world, laparoscopy seems to be associated with a higher rate of serious complication. And I think this just shows us that we have to be avoid being complacent about laparoscopic surgery. There's enough expertise out there now, and we know with these programs that have been set up in England that there is enough expertise out there to avoid people having to go through their own learning curves. And it's very important that we make sure that not only our trainees, but our consultants who are practicing laparoscopic surgery are adequately trained in this, what to me is a very difficult technique. So if we move on to cancer control. So here is Bill Heald in the Times in 1996. And I don't think we can underestimate his contribution in pointing out to us the importance of total mesorectal excision. And here's this iconic diagram that we're all very familiar with, and the importance in obtaining an intact mesorectum in preventing local recurrence. And we're equally familiar with the work of Phil Quirk, who showed the importance of circumferential margin clearance in improving outcomes, and again emphasizing the importance of the quality of the mesorectum. And here is three categories of mesorectum, and you can see here's a complete mesorectal excision with good margins. Here's an incomplete mesorectal excision with rents through the mesorectum right down to the muscularis. And it's not surprising that outcomes are worse with this type of surgery than with that type of surgery. And here are data from CR07 looking at local recurrence by plane of surgery. And here's the incomplete mesorectum here, and this is the complete and nearly complete here. Significant increase in local recurrence despite the fact that the stage of disease was comparable in these groups. And this is some work done by Peter Wilson in our department, who carried out a very detailed human reliability analysis in over 100 anterior resections. And what he showed that there was a correlation between the number of mesorectal injuries and the number of non-consequential errors carried out in the whole operation. And you can see the numbers are huge in some cases. And I think what this shows beyond any doubt is that mesorectal injuries reflect the care with which the whole operation is carried out. So just when we thought we'd cracked rectal cancer, these data came along from Leeds, which showed that local recurrence was worse after abdominoperineal excision than after anterior resection, and so was cancer-specific survival. And again, there was no real difference in the stage between these two groups. So why is abdominoperineal excision inferior to anterior resection? We always used to think it was a better cancer operation. Well, these data in 2005 from Holland, I think, demonstrate the answer here. So circumferential margin involvement tends to be higher in abdominoperineal excision than in anterior resection, and intraoperative perforation tends to be higher in abdominoperineal excision than anterior resection. So how can we avoid these potentially catastrophic outcomes? Well, one answer, firstly, I suppose the first answer to me is blindingly obvious. Not everybody agrees with this, but to me it's very obvious, is you do the perineal operation with the patient in the prone position. And if you don't do this, you should try it, because you can see what you're doing and your assistant can help you. And since we introduced this into Ninewells about 10 years ago, the problem of intraoperative perforation at abdominoperineal excision has disappeared. However, there's still a problem. So here is one of our early resection specimens, and you can see beautiful mesorectum here, but it peters out here so that just above the anal canal we are down onto the muscle tube. And of course, the patients who are having abdominoperineal excision have tumours down here, and so this dissection plane is going to expose these tumours. In fact, you can see a bit of it poking out there. So what to do about this? Why does it happen? I think it happens because we have trained ourselves to follow the mesorectum very carefully down to the pelvic floor, and then we do the abdominoperineal excision as an afterthought. And it fell to Torbjörn Holm in Stockholm to point out that what we should be doing is stopping the rectal dissection relatively high and actually excising the pelvic floor. And here are some operative photographs. We've found it useful to excise the coccyx here, to divide the levator as far laterally as possible, to take the rectum out, which then gives you a very clear view of the plane between the rectum and the prostate here, and of course in the vagina if you are preserving the posterior wall of the vagina in a female. And this makes this part of the dissection very clean and potentially bloodless. And here we have the results. So these are these old-fashioned types of APs which are tapering down to the anal canal, and now the types of specimens we're achieving are cylindrical, the cylindrical abdominal perineal or extralevator abdominal perineal excision of rectum. And these are data from a multi-center experience that we contributed to, multi-center, multinational groups of surgeons carrying out this extralevator operation. And you can see here's the positive circumferential margin, this is the extralevator, this is the standard AP, intraoperative perforation, extralevator, standard APE. So perhaps we are, if you like, going back to the past. We're reinventing the past. This is Ernest Miles, and it's likely that this is the type of operation that he ended up doing. But there is little doubt that by adhering to these principles, we will improve cancer outcomes in patients who are undergoing abdominal perineal excision of rectum. It doesn't come without a cost, though. And I'm not going to we just don't have time to deal with the problems of closing the perineal wound, but I'm not skipping over that because it's not important. It's very important. But I want to draw your attention to the fact that perhaps in some patients with early rectal cancer, radical surgery is actually over-treatment. And of course, we are seeing a lot of early rectal cancer with screening. And thanks to Gerhard Buss, who sadly and very prematurely died last year, we have transanal endoscopic microsurgery, which allows us a very precise method of full thickness excision of the rectal wall, so that we have the tools now to carry out safe and effective local excision of rectal cancer. But of course, we know that even T1 tumours are associated with residual disease, and if we look just at lymph node involvement, if you have a T1 tumour that involves the whole of the submucosa, then you have substantial rates of lymph node involvement. So that for most patients, local excision cannot be regarded as sufficient treatment. And for this reason, headed up by Simon Bach, we have the TREC phase 2 feasibility study for T1 and T2 tumours, which is attempting to randomize between total mesorectal excision and short course preoperative radiotherapy, followed by excision of residual tumour at 8 to 10 weeks. Now, this is a real challenge because, of course, a good total mesorectal excision for a T1 or a T2 tumour will be associated with negligible local recurrence rates. So to produce an adequately powered non-inferiority trial would require thousands and thousands of patients. And it's really open to speculation whether this will ever be achieved. But at the moment, we do have this option, and I believe that in patients with early disease, you have to have a frank discussion with them about disease control and operative morbidity, and a decision has to be made with a fully informed patient as to which approach to take. So finally, I want to touch on colon cancer. So these are data from Scotland, and what it shows is that the 5-year relative survival between 1986 and 1995 was better for colon cancer than for rectal cancer. But from 1996 onwards, this trend was reversed. And we want to know why this is the case. Now, if we look at these data from Tayside, you'll see that having a right colon tumour is a significantly independent adverse feature when looking at hazard of recurrence and death when compared with rectal cancer and when compared with left colon cancer. And here are data from North Yorkshire that Phil Quirk kindly let me have. And what this shows is that the difference between specialists and generalists in terms of their colon cancer survival is greater for colon cancer than it is for rectal cancer. So have we learned something with rectal cancer that we still have to learn for colon cancer? And I believe that we certainly do. You see this diagram of the mesocolon. It's quite easy to expose this tumour by breaching the mesocolon or to expose a lymph node by breaching the mesocolon. And you can see here how dangerous this can be. Here's the tumour, very easy to come through here into the mesocolon to expose this tumour. Very easy, in fact, I think this has happened here, to come up against this lymph node here and expose this lymph node. Now, radical lymph node dissection is quite common practice for left-sided cancers. A lot of us are very familiar with dividing the inferior mesenteric vessels close to their origin, hence getting good lymph node yield. But much fewer of us have been practicing tying the right colic vessels at their origin from the superior mesenteric vessels in order to obtain a resection specimen such as this. And again, this concept of planes can be used. Again, I've got some slides here from Phil Quirk, and he has subdivided the colon specimens into poor or muscularis propria specimens or good total mesocolic specimens here. And in Leeds General Infirmary, you can see that only 32% of colon resections were carried out in this ideal mesorectal plane or mesocolic plane. And if we look at left colon, the proportion that are excised with a good mesocolon is better in the left colon than in the right colon or the transverse colon and flexures. And these data from Leeds General Infirmary again show that these different planes of colonic surgery separate out very nicely when you look at survival probability. So again, unsurprisingly, we find that the quality of surgery is important as much as for colon surgery as it is for rectal surgery. So the principles of colonic excision, I think, are again very simple. A good mesocolic excision, adequate lymph node clearance, and circumferential margin clearance. And just as we have Bill Heald to thank for pointing out the way in rectal cancer, I believe we have to thank Werner Hochenberger from Erlangen, who first pointed out the importance of good radical surgery for colon cancer. So to conclude, I believe that optimizing outcomes from colorectal cancer surgery, and of course just surgery in this context, is quite simple. There are three basic premises. Firstly, we need to detect the disease early, and then surgery will be effective. Secondly, we need to pay attention to good, careful perioperative care, and I do believe that preoperative optimization is something we really need to work at in the next few years. And thirdly, and perhaps very obviously, careful, appropriate surgery. Thank you very much.